Hello everyone, welcome. It's 7 p.m. in France, Paris time, Berlin time as well. Welcome to the Septodont webinar. I'll just give a few more seconds for people to come join us. Already quite a few people on the line. Happy to see that, and numbers rising. I'm very happy to be today to present to you Dr. Sascha Herbst from Germany, who's going to be with us for this webinar, which title is Beyond Obturation. So we'll know, I'm guessing we'll talk about endodontics, but we'll see that later on. Dr. Sascha Herbst is, well, strictly speaking, an endodontist and works at Charité Berlin in Berlin, in Germany. He's the deputy head of the Department for Oral Diagnostics, and he has a very wide university background, specialized in digital health and health services research. Maybe Dr. Herbst, you'd like to tell us a bit more about yourself?
Thank you so much for introducing me and the warm words. I'm a dentist since 2016, and I'm focusing on endodontics since day one. So I fell in love with endodontics during my dental school, and since 2019 I'm a board certified endodontist, and I still love endodontics, and I will until my retirement.
Oh, you're getting ahead of yourself, but that's good.
Yeah, just setting aims.
That's very good. So today we'll talk about endodontics. That's a very wide subject, and obturation, but of course there's a lot more to it. It's your favorite subject. I see people are still joining us, but actually let's get into knowing our audience now that we know a little bit more about Dr. Herbst. We'd like to know more about you guys who are on the line, so that we know, well, what you will learn from this lecture, maybe. So we have prepared a few polls for you, a few questions that you'll see on your screens. Easy questions, there are no right or wrong answers, just to know more about yourself. First question that we want to know, and we want to know about you, is your specialty. So I'll launch the poll right now, and you should see it on your screen, I think. So, are you a general dentist? Are you an endodontist? Or are you something else related to the field of dentistry or not? Doesn't matter. But who are you guys? We want to know more about you. Let's just keep it up for a minute longer. I already have quite a view on the answers, and I have to say I'm not surprised, but it's very good, and I think that you will learn from this lecture. Ooh, names are still moving, so let's get them. Yeah, it's about a minute. Oh, you almost all voted. Great audience so far. I'll close the poll right now, so that Dr. Herbst, you can see on your screen, I think, the results for this poll. Can you see it?
No, I can just see the poll.
Okay, I'm sharing it.
Yeah, that's what I expected. Most of you are general dentists, and I think it's perfect prepared for you. So I hope you will gain some insight from the endodontist perspective on obturation. And yeah. So
a lot to learn for everyone, actually. We learned a lot when we prepared this webinar. That's still very interesting for general dentistry.
Yes, because it's not just about the boring technique. It's about caring for our patients, to see the outcome and to talk about repair and healing. And I think it's quite interesting to emphasize on the role of the sealer in the endodontic procedure.
Great. Let's know more about you guys again. So when you actually practice endodontics in the audience, which obturation technique do you use? Because as you know, we are going to be talking about obturation today, so we actually really want to know what you're using. So you have warm vertical compaction, warm technique, and two cold techniques, either single cone or lateral condensation. Interesting results. It's very tight, actually. Come on, guys. You can do you can do more. 60% voted. I'll leave it for a few more seconds. But I think Dr. Herbst, your view will be interesting for these people, for this audience.
I hope so.
Okay. It's always interesting, but I think that for the audience may give them a complete view. Okay, so I'm closing the poll and I'm sharing the results.
Oh wow!
Did you,
I wouldn't have expected that. Yeah,
really?
use the warm vertical compaction technique. Yeah, but surprising that most general dentists are using warm vertical compaction techniques. So it's very interesting to see the differences between or across the countries, because most general dentists in Germany don't use warm vertical compaction. They are using either a single cone or lateral condensation. So it's very interesting for me to see, and I hope that you can gain some insights and you maybe reconsider your protocol for a single cone technique. Maybe, let's see.
We have a lot of people coming from basically all around the world. So yeah, no.
Yeah, that's what I do.
Yeah, it's maybe a bit different than only Germany. So there are different practices all over the world. There's one last poll because we really want to know more about you guys. There's one last thing that's that we want to know. It's which type of material you use for obturation. So this poll is not one answer only; it's a multiple answer possibility. So you can choose the one that you use mostly as a sealer. If you don't know, you can say you don't. I met with many dentists who weren't sure or did not know, and it's not a problem. But once again, I think that's going to be very different because the techniques and the material used are different all over the world. So since there are very many different countries. So, okay, I'm leaving it for a second more. Just so you know, because I'm getting questions already, yes, we are going to be speaking Spanish in a few minutes. Not speaking at least, but there will be subtitles in Spanish for the whole lecture in a couple of minutes. So for our Spanish-speaking friends, please hold tight. You will see them in a minute for the whole lecture. Thank you for voting. And this was the last poll, so I'm sharing the results on the screen. Dr. Herbst.
Okay, and that's also not a surprise because the epoxy or resin-based sealer is currently the gold standard, which every study is testing against the new materials. But I see also a good proportion using BioRoot RCS. So I hope that the guys who are using BioRoot RCS are getting some new insights for the material or for the use of the application. And yeah, for sure, as a zinc oxide or regional-based sealers are also a very common material. But I think I would say a little bit outdated. Yeah, but I'm very interesting about the discussion afterwards about the materials, and maybe one can share their experience with a zinc oxide or eugenol-based sealers as well.
Yeah. Great. So thank you very much, everyone, for partaking in this poll so that we know more about you. What we'll do right now is we are going to play the recorded video that we actually grabbed a couple of weeks ago so that we had time to put the Spanish title on. Please ask your questions in the dedicated questions box. We will see them during the lecture and we will be able to ask them to Dr. Herbst at the end of the session. So we'll have a Q&A session afterwards. So please don't unlog right after the lecture. I'll say we'll be back. So sit tight, enjoy the show, and we'll see you in about 15 minutes. So let's go.
Thank you for having me. And I would like to discuss the interesting topic beyond obturation. And we are just discussing that the obturation procedure is not just about putting material in the root canal system, because we can care more for our patients with the new sealer of BioRoot RCS. But before we deep dive into the topic, I just want to borrow some basic principles from art when it comes to minimalism. In this famous painting, Pablo Picasso tried to reduce the painting to its minimum, but the goal was that the subject should be recognizable at the end. So the same principle we can apply also to endodontics. We can simplify and demystify our procedures by discarding every detail or the unnecessary treatment steps. And in this painting, you see that we have a very detailed drawing of a torus. And finally, after discarding all the unnecessary details, Pablo Picasso ended up in a one-line drawing of a torus. And we see that we can still recognize it as a torus. And we'll do this for endodontics as well. We'll discard all the steps, and then we will also have at least the same good results as we have with the more detailed procedure. And the same is true for medicine. We see here one example of an open pancreatic surgery, and you can see that the cutting line is huge. And my dad was suffering also from this surgery, and he was just a couple of years older than me, and I could see his suffering all the years from the scars and all the side effects. And today, when I would receive such a treatment, the whole procedure is possible through keyholes. So we don't need to cut the whole body, and we will have less suffering in the end. And that's also my motivation to reduce all the unnecessary treatments when it comes to dentistry. And now we focus on the main principle of an endodontic treatment. We have here one tooth with a deep caries, with a necrotic pulp, and a periapical radiolucency. You can see them at the apex. And then, after just removing the infected tissue and a good disinfection, we can obturate the whole root canal system, and we can stabilize the disinfection effect. And that's what a good obturation is about, a tight seal of all the caves in the root canal. And it works quite well. We see in the literature that we have about a success rate after several years of about 93%. That's really, really good. But we have to keep in mind that about 42% of the root canal treatments in Germany are insufficient. And accordingly, we see a prevalence of about 43% of apical periodontitis just after root canal treatment. So we have to keep in mind that these very good outcomes are just achieved in a university setting, and that the reality is quite different, because the whole procedure is very, very difficult, and we have also some bottlenecks in the treatment. We have a loss of the dentin, especially in the cervical area, which is very crucial, and we reduce the amount of dentin also in the root canal due to the preparation procedure. And of course, we have a loss of function. When we remove the pulp tissue, we have reduced to no proprioception, and we have no immune response in the root canal. And at the apex, we have a very difficult anatomy, which is quite difficult to obtain patency in all situations. And finally, one big enemy is the vertical root fracture. And the prevalence is up to 30%, but not every case is symptomatic and needs to be extracted. So the occurrence of vertical root fractures is far more higher in root canal treated teeth compared to teeth with vital pulps. And even in my cases, I observed some vertical root fractures. So when you're living in a cluttered house, you will find a way to minimalism. And when you have to deal with your own endodontic complications, you will find a way to minimal endodontics as well. And we all see our failures sometimes, and we cannot achieve always 100%. And that's why I questioned and challenged every treatment step in my current protocol several years ago. and I tried to improve these steps. And here's one case of mine from my classical protocol in 2019. We see here a case of a symptomatic pulpitis, and I performed a conventional root canal treatment. And I did it with a warm vertical compaction technique, and I was convinced that's the best way I can treat my patients. But then I challenged every treatment step you can see on these X-rays here, and I relied therefore on the current research. The first one is that we can maintain pulp vitality even in symptomatic cases. And when we see that we have an extended bleeding or a deeper inflammation, we can just consider not to treat all root canals and to preserve the healthy tissue in the root canals. I will explain it later. And then we have to consider if the warm vertical compaction technique is the best idea in every cases. And finally, we have to think about reducing our preparation size, because you can see that this technique requires a huge amount of loss of dentin. And now we will try to focus on the loss of function. In this case, we had a symptomatic pulpitis. And nowadays, I treat these cases mostly with vital pulp therapy. We have here on the right side the preoperative condition of a severe pulpitis. And then we can just remove the infected tissue here and place our pulp capping material, the biodentin, and that's it. That's the whole treatment of this symptomatic case. And I think many dentists would go for a conventional root canal treatment, but you can see even after 20 months, the patient was still free of symptoms and you can see healthy periapical tissue. So we have to keep in mind that the pulp is a very resilient and sometimes also underestimated tissue. And then I will tell you about the idea of not treating all the root canals when we have vital tissue in there. And I just want to talk about a failure of mine. In this case, on the left X-ray, you see a pulpotomy after removing the coronal amalgam restoration. And I thought it would be suitable to do a VPT also in cases of an infracture. So we had some fracture lines and the tooth got symptomatic, and I decided just for a coronal and pulpotomy. But then after several months, the patient appeared again with some symptoms, and I was forced to remove my biodentin capping here. And then I considered to do the full root canal treatment. But then, even after removing the biodentin, I recognized there that there was some dentin in the distal root canal where the pulp should be. And then I was just wondering if the pulp would be vital, and I placed a cold foam pellet there, and the patient responded to this cold testing positively, and I was really surprised. So is there a rationale to remove the healthy tissue, which is capable in building dentin, or should we cap it and just treat the first root canal, the infected one? And I decided for the last option, and you see that even after 2 years, the situation is stable and the patient is free of pain and you could preserve tissue. And this is a concept I very much appreciate, and you see that it works in many cases. And we are also happy that we could publish a little case series in the Quintessence journal, which was also translated to French. So it was the first article I've written by myself, but I couldn't understand anything. And on this picture, you can also see that we have good weather also in Berlin. So our first conclusion is that the biodentin interacts positively with pulp tissue. And that is also an important fact, because sometimes we do a pulpotomy even in cases we don't expect to do. Imagine just a lateral root canal, and there's just some pulp tissue in the horizontal direction, and we just cut the tissue, and then we have also the effect of a pulpotomy. And now I want to show you another case where we had to manage a complication after dental trauma. Because I'm also deeply rooted into dental traumatology, I have also to deal with some complications even after the first emergency treatment. In this case, the coronal segment was avulsed and completely out of the socket and was replanted by a surgeon, but he didn't make a post-operative radiograph to check the new position. And you can see still a gap between the coronal and the apical segment. And if we do nothing, just connective tissue will invite, and we will have a not so good healing, and the coronal segment will be mobile even after several months. So we would love to have some bone tissue there, but the bone tissue is much slower in regeneration compared to connective tissue. So what should we do? We should consider to push a biomaterial in this fracture line, because the silicium helps the odontoblast to differentiate. The hydroxyl ions can inhibit the bacterial growth, and the calcium ions have the cell differentiation and the mineralization process. So we have the opportunity to induce some bony healing when we just place our biomaterial, the biodentin, in this fracture. So I intended the biodentin as a bone magnet. And it was a bet, I guess. But after 7 months, you see the perfect bone healing in this fracture line. So that's just my evidence that we have also a positive effect with the bone. And we have to deal with bone tissue. Even in these cases, even after the peri-epics, there's also bone tissue. And so we have to keep in mind that the biodentin interacts positively with the pulp and with the bone. And the good thing is about that we have a sealer, which is based on the same technology like the biodentin. It's called the active biosilicate technology. And the BioRoot sealer is the only sealer which has more than 40% of tricalcium silicate in the final setted mode. So there's a link between both materials, and so I was also convinced to use the BioRoot as a root canal sealer, because I have good experience with biodentin. And now let's challenge the idea of performing warm vertical compaction. We see here this case, and the use of the warm vertical compaction technique is very risky because we have a close proximity to the sinus. And you see that the apex of the tooth was just covered by a small layer of bone. And I want to be a hero dentist, and I just wanted to obturate the side canal at the apex. And I focused more on obturating the deep split than respecting the complex anatomy in this case. But we have to keep in mind that we don't treat X-rays. And in this case, it went well, but there are also cases where it fails. And this was a case report published in the Australian Endodontic Journal, where a dentist pushed sealer beyond the apex. It was a zinc oxide eugenol sealer, and it was performed in the cold lateral compaction technique. In general, we have to consider that the warm vertical compaction technique requires more pressure than the cold lateral compaction technique. So the risk of a sealer surplus is the highest in the warm vertical compaction technique, followed by the cold lateral compaction, because we also apply some pressure during the obturation procedure. And the technique which offers the most least pressure is the single cone technique. And the whole case ended up that the patient got symptoms because the sealer was extruded into the mental nerve, and they had to do the surgery and to remove also the apex. So it was a huge mess to remove everything. And so you have to consider if the warm vertical compaction or the cold lateral technique is still the best choice, because we have everywhere a difficult anatomy and the risk to harm the patient with our materials. So when we harm our patient with materials like the zinc oxide eugenol sealer, which shows also an initial cytotoxic effect, we have to consider if there are not better materials. So the bioactive materials are more biocompatible than the zinc oxide eugenol or the epoxy-based sealers. So when you have to choose a material, I would rather choose a material which does not harm the body, but will also support the body in healing. And now let's talk about the preparation size, because it's also a crucial step in endodontics. For the warm vertical compaction technique, you need space to do it properly and to achieve the 3 millimeters at the apex with good aperture. So you have also pressure in any direction, and you increase the risk of the root fracture. And imagine also the plugger application. You have, even with plugger based on 90, forces which offer the risk of the fracture of the root. So we have not just the loss of dentin, which is obvious, we have also the stress concentration in the cervical area. And you see that the apical preparation size seems not to have the same impact like the cervical preparation. So the apical enlargement is okay based on the underlying anatomy, but we have to keep in mind that we just use a smaller taper. And the warm vertical compaction technique loves big tapers because you have to achieve the apex with the instrument, with the heat plugger, with the cold plugger. And so there's some contradiction between the need for a minimal preparation size and the use of cold lateral compaction or warm vertical compaction. And this is also highlighted in a current journal, that vertical root fractures can be avoided by minimizing the canal enlargement in every step and the apical condensation force. And we have apical condensation forces even during the preparation and during the obturation stage. And now let's compare the obturation concepts here. We see that we have in the warm vertical compaction technique the demand for more good aperture than sealer, because mostly you don't trust in your sealer and you want to have the good aperture also in the laterals, as you can see in the left picture. On the right side, you see that the amount of sealer is irrelevant. So you don't ask for more good aperture, you are asking in these cases also for more sealer, because the sealer has a bioactive effect. And you see also in the lateral root canals here highlighted and with white that there's also sealer in the lateral root canals. And now compare the sealers, because you can also perform the single cone technique with epoxy resin based sealers, but you see, as I've mentioned before, that they show an initial cytotoxic effect. And still after setting, the material is still inert, but it's just the current gold standard. So the sealer is just tolerated by the body. And now let's have a short view to the calcium silicate based sealers. And we see that these sealers show a high biocompatibility and high antimicrobial activities as well, but they do not harm the body, and the opposite is the case. And these sealers induce the release of growth factors, so we have a support during the healing process, and the sealers are also modulating the inflammatory process and the regeneration, as we have seen with the biodentin. Just to remember, the biodentin and the BioRoot are connected to each other based on the same technology. And when we consider the best preparation size, we can look into the literature and find a clinical trial which compared different preparation sizes and the outcome. And we see that the preparation size of 25.6 or 30.4 are enough in the majority of cases. We see that we have to enlarge the cases, and we see failures when we go under these values, but we don't need to go higher than these values. So we have very good results with 25.6 or 30.4, depending on the anatomy. And now let's have a look at this case. We see that we have a double S-shaped anatomy and a very long root canal of 24.5 millimeters. And just imagine the stress on the root when we prepare up to 35.6, when we want to have a good condition for bone vertical compaction technique or for cold lateral compaction. And we have just a huge amount of stress on the tooth. On the instrument, you have a higher probability of the fracture of the instrument. And just imagine also the stress when you apply the plugger. For cold lateral compaction, you will also place your spreader, and you have also some longitudinal forces there, and especially for the warm vertical compaction technique. And I decided to obturate these canals with BioRoot RCS and single cone, and you can see that it's a very good result in here. and it's very time efficient and efficient in general. So I just place my sealer, I just place my gutta percha point, cut it, and that's it. And now let's compare this treatment outcome with my old protocol. And you see the difference. You see the less preparation in the cervical area because I have no need for the plugger application in this area. And I do not need to straight the access cavity for the plugger. And that's great. That's minimalism in endodontics. But we have also to have a look into the controversy studies. Because when we have a new procedure or new material, we start with an assumption, then we go for in vitro studies, for clinical studies afterwards, and then we have our conclusion. And let's have first a view into the in vitro studies. We have to keep in mind in general, when we look into the in vitro studies, that most of them try to simulate the clinical situation and that these are still models and they are not comparable to real life because they try to modulate the real life with less effort and with simpler settings. And it's just an approximation for our first understanding of the material. So we need them, but we have to be careful with the interpretation and the clinical application. So we need to be critical with the studies because some settings and norms are not evolved at the same rate as the sealers. So we have some gold standards like the epoxy-based resin sealers, but all the models are improved based on these material. So for an example, the solubility tests are not comparable, the whole procedure, with the properties of hydrophilic sealers. So there's a discrepancy between the settings and the material properties. So we have different generations between the materials, but not different generations between the artificial models here. So sometimes these settings are a bit sloppy, and sometimes research groups have some pressure also to publish a lot of papers, and some journals are not much critical. So we need to have our eyes open when we interpret these results. In this study especially, we see that they used an acrylic tooth replicate. And what's the idea behind this? Because we have an interaction with calcium silicate-based sealer with a dentin, but we have not an interaction with the acrylic surface. So these results in this root canal, when we compare push-out, bonding strength, or whatever, they are not comparable to the real world anyway. So these results I won't take into consideration when I have to select a sealer. Another common procedure for evaluating the sealers is the amount of voids in the obturation. And I think it's also relevant, but you have to have a look into the methodology and to see that there is an equation which looks good at the first glance, but when you go deeper in this equation, you see that it's mixed with the clinical relevance, the gap volume between the gutta percha and the dentin wall, but they added the void volume in the whole obturation. And I think it's really questionable if the void in the gutta percha, for example, or in the set sealer has a clinical impact. I would say no. Other research groups say also no, but it's still in the equation here. And so the whole result is not reasonable to make a decision based on these findings. So when they say, okay, we're just comparing the gap volume, it would be more clinically relevant. But you find these examples in many studies. And even when you say the warm vertical compaction technique will offer less voids compared to any other technique, we have to keep in mind that's not the technique is the problem, it's the dentist, or me in this case, is the problem. And even when you do a warm vertical compaction technique on a regular basis, you will see some well, not so optimal root canal fillings, as you can see here, one of my cases. You see that we have a sealer extrusion through the pressure. Sometimes you can't avoid because you're working in the dark, you're not seeing everything, even under a microscope. And then I tried to reduce the gutta percha to 3 millimeters to the apex. And then after the downpack, the further increments are not properly condensed, and you can see here a void in the apical region. And as well in other increments, here are also voids. And you can also see the voids in the difficulties of the anatomy. So the warm vertical compaction technique is a very sensitive technique and complicated. And it's better to minimize the protocol, to apply the principles of minimalism to less steps, and we will have a more predictable outcome. And we need to simplify our steps. So the obturation is not just a matter of specialization. So with a very simple but predictable outcome, every general practitioner can provide a very good obturation. And now let's talk about the capability to retreat calcium silicate-based sealers. First of all, I have to mention that I have no experience or not experience which I recognize, but because sometimes you can't say it's a calcium silicate-based sealer in the clinical scenario or not. And I was not supposed to retreat my own cases so far. But I had to remove the biodentin in my failed experimental cases, as you might remember, the first one. And I can remove the biodentin, and it has similar properties to the dentin. And when I imagine to remove the biodentin, I would guess that it's also possible to remove the BioRoot RCS in a set condition, even with our rotaries. So I think it's not a real problem. And you have also to take into consideration that the core of the obturation material is still a good aperture point. So the principle of the retreatment is still the same. And I've just to show you a study. You can see that they compared in an in vitro setting the BioRoot with MTA fill apex and the gold standard AH+, and they used 19 teeth. And the conclusion was that the calcium silicate-based sealers were more retrievable with less retreatment time. And you will find studies in PubMed which state exactly the opposite. And that's what I mentioned earlier, that these studies are sometimes not very conclusive. So you have sometimes to make your own experiences, and you have to keep your eyes open when you decide for a sealer based on these in vitro studies. And I just want to make a difference between these mechanical studies, which we discussed, and the lab studies when we're comparing the cells. And when we're just researching for the cells and the reaction to the material on the cells, it's a complete different story because we have no other opportunity to test the cells and the biocompatibility with these materials. And now let's have a look into the clinical studies. Here's one classical study from NG et al. From 2011. And this study was very, very good because they found out the basic principles when it comes to a good root canal treatment. They found with 700 teeth, and they found out that the presence of an apical lesion, the presence of the sinus tract, have an impact on the outcome. Another principle was the obturation. You need to have patency. It's a good predictor, and it's a good approximation for the obturation length. And another negative impact had the obturation beyond the apex. So we can say that the proper obturation has a good impact on the outcome of the root canal treatment. And these are basic principles they could figure out. And you see that the applied model has a very good goodness of fit, almost of 1, and I'm really jealous about this model because I try also some models, but they don't have such a good fit, but it's a quite different story. And when we follow these principles, we have a high probability to have a successful root canal treatment. And then we have to compare clinical studies where we're not just figuring out about the basic principles, but then when we want to investigate the differences between some strategies, which is the case in this clinical study. We see that this study tried to compare the warm vertical compaction technique with a zinc oxide eugenol sealer and with single cone and BioRoot RCS on 69 patients. And they found out that the BioRoot RCS had a better outcome of 97.4% compared to the warm vertical compaction technique of 93%. But we see that there was not a statistically significant difference in there. And that's a problem, that the sample size is not enough to make such small differences visible. So we have here a hint that the BioRoot works better, but we can't say that there is a statistically significant difference in there. And we have to summarize that the epoxy resin-based sealers are just tolerated by the body. They show an initial cytotoxic effect, and they're just inert after the setting when we have to make our decision. And finally, the calcium silicate-based sealer, like the BioRoot RCS, show very good performances when it comes to the clinical application, because they modulate the inflammatory process and they induce the release of growth factors. And these are the main properties which I really like when I try to give the best to my patient. And now I just want to give you some examples during the clinical application of the material. One concern of some dentists and even specialists is that we can't perform a 3D obturation. 3D means that we could obturate all the anatomies and all the caves in the root canal system. And I can say it works quite good with a single cone and bioceramic sealer. As you can see here, it was a very complicated retreatment with a ledge formation in the mesial root and with thermophilic carriers. And even after a good cleaning and a good shaping, we were able to fill all the anatomies here. You see a mesial and distal, all the laterals filled, and that's also possible with less pressure. So when you want to have this effect with good aperture, you need to put so much pressure on the root that I wouldn't wonder if it fractures. So that's also the point of a hydrophilic material. The hydrophilic material loves the water and follows also the water when we have a moist environment. And we have to keep in mind that the epoxy resin-based sealers are a hydrophobic material, so they hate water, and so we need to make more effort to obturate all the side effects and side canals. And that's the reason why some authors say to use ethanol or some other things to dry out the dentin. But when we dry out the dentin, it's more prone to fracture. So back to our hydrophilic calcium silicate-based sealer, the BioRoot. I would recommend to do the final rinsing with either sodium hypochlorite or sterile saline, because we have a different mode of bonding. The sealer, the BioRoot, will bond to the calcium phosphate, and when we rinse, for example, with EDTA, we would harm these crystals. So it's a quite different story, because the epoxy resin-based sealers bond to something else, but it's now irrelevant. So keep in mind just to rinse finally either with sodium hypochlorite or saline, because it will strengthen the bonding. And here we see also the evidence that the sealer is also invading the dentinal tubules in the confocal laser study. And I don't want to expand on this, but I just want to show you these beautiful pictures. And now let's talk about the healing capacities in the use of BioRoot RCS. We see here 3 cases, but I just retreated the first molar later than the both premolars, because the patient got pregnant in between. And we see here in the first premolar, there's also a perforation present. So it was a very interesting and challenging case here, and we still see the apical lesion in the first premolar. We see here the old obturation material, and we see here the first glance of the perforation. In the first step, we have to make sure that we remove all the material in the obturated root canal, and then we have carefully clean the perforation site. And then we end up here. You can still see here the perforation, everything's cleaned, and we still see here the bony tissue. And then we go for our length control to see if everything is still removed and to see the prep result. And in between, I decided to cap the perforation, and you can still see the biodentin perforation capping in this area here. And here's the complete clinical situation. You see here the perforation capping with the biodentin here. And now I will show you how I apply the BioRoot RCS in a clinical situation. We see here the access cavities. And then I apply drops of the BioRoot with a good aperture point. And I go drop by drop and carefully apply the sealer. And it's important to mention that you don't need a microscope to apply the sealer properly. I would recommend always to have some loops for an endodontic treatment, but you can also apply the sealer without loops. But I would recommend at least to have some loops for the whole procedure and not even just for the obturation procedure. You'll see here, that I incrementally fill the root canal with the sealer, and I give some pressure there to be sure that the sealer will get on each surface. And I put also some shaky movements on there because the sealer has also the thixotropic effect, which I also love from the biodentin. And when you have some shaky movement, the sealer will flow in each cave. And I've now speeded up the whole procedure for the first premolar because it's the same as I do for the second. And you'll see that I use still some drops because it's easier to apply. And then in the final step, I choose a good aperture point. And now you see that I try to insert the good aperture point, and I see that it doesn't have a good fit. And then I decide to use another good aperture point, and it's no problem because you can just apply more sealer in the cavity, and then you can just exchange the master point when you feel the difference between the first fit and the second fit. And then I'm very careful because the good aperture point will press the sealer beyond the apex when you're pushing it too much. So just a slight pressure to have the good fit. And then I use the heat plugger and cut the good aperture points. And in this step, I try also to seal the entrance to the root canal because it's very important to secure the obturation to the water. And because the sealer is water soluble, when you give water to the sealer, it will just flow away. So just be careful that you're able to create a tight sealing, and it's no problem because you just can heat in the good aperture and then you can seal the entrance. Then I use a foam pellet first to make sure that my condensation is properly, and then I correct it. I put some heat on there, and then I press again the good aperture. And then after I'm sure that everything is still saved, I apply the water, and you then can just see the clean cavity. And what I love is to apply a sandblaster because the sandblasting will clean everything perfectly. But as you've seen, the sealer will also will be removed during the water rinsing procedure. So there's no need for the sandblasting, but I love it because I have a very clean surface. And here's my algorithm summarized. When I decide to remove the good aperture, I just first use a foam pellet to remove the sealer to make sure that my condensation is properly performed. And then I come with the water, and then the risk that I will rinse out my sealer from this area here is reduced. And then I dry the cavity, and then I prefer to use a sandblasting. And now we see here the post-operative radiograph. You still see the obturation with the BioRoot sealer, and I really love to make composite fillings deep to the root canal filling. And yeah, that's the situation after 1.5 years. And now you see the almost perfect healing at the first premolar, and you see also the successful perforation capping with the biodentin in here. And now we zoom into the preoperative radiograph and see here the apical lesion. And 1.5 years later, we see the perfect healing here. And we still see that we have a periodontal ligament present there. And that's also the evidence for me, the clinical evidence that the sealer is interacting positively also with the periodontal ligament. And we see here highlight again our criteria for the calcium silicate-based sealers, the high biocompatibility, the antimicrobial activities, and the modulation of the inflammatory process. And now I want to discuss a very special case. And I love special cases, so I also love to present them. What is special about this case? The complete treatment planning was a bit difficult because, as you might see here in this area, the first molar showed here a resorption. So the tooth is non-restorable. But when you remove the tooth, you can see that the lesion of the distal root canal communicates with the lesion of the second molar, and we have also a connection to the impacted third molar. So when we remove this tooth, we have a tunnel defect reaching to the wisdom tooth. So we had to avoid the extraction of the tooth. And so I decided to do a selective root canal retreatment. So I retreated the distal and the lingual root canal and still left the obturation material in the mesiobuccal root. So we don't have to emphasize on the healing of the mesial roots. And the second molar showed a pulp necrosis, and there was a huge swelling in the vestibulum, and the patient attended to my office and wanted to have my opinion in this special situation. And I decided to make a split mouth design in this special situation because we have highly infected teeth. We have infection in 4-6 and 4-7, and I thought it would be a good comparison of both techniques. In the last tooth, I applied the single cone technique with BioRoot RCS, and in the first molar, I just did my warm vertical compaction technique with IH+. And you see that due to the technique, you see here the surplus of the sealer. And here we see also the old obturation material, which are still left in the mesiobuccal root, but I explained the reason why it was just still present. And after 1 year, or 14 months, we see the recall picture here. And what we see is still amazing because we see first the closure of the connection. So the main goal was achieved. So we have no communication between both lesions, but we see at tooth 4-7, which is obturated with a BioRoot RCS sealer and a single cone technique, that we have a periodontal ligament still present there. That's the periodontal ligament, as you might remember from the first case here. And we see also that we have no bone attraction to the inert epoxy resin-based sealer here. So we see still a lesion around the sealer. And when we compare it to the ABS material, the active biosilicate and brother, the biodentin here, we see that the bone loves this material. So we see here present a lesion around the material, and here we see the bony integration of the biodentin here. And that's the next generation, what I say, of the bioactive materials, which interact positively with the tissue. And that's, for me, the reason why I would call this technique beyond obturation, because it's a very different story of healing and interaction with our tissues. And another good thing about the simplification of the whole procedure is that we are able to obturate also large root canals in these situations. And most of the dentists would refer these cases to an endodontic specialist, but I would say that these cases are also manageable in the general practice with the single cone or multiple single cone technique, as I will describe in the next slides. And you won't use the cold lateral compaction technique for this, and I will explain the procedure in the next slides. And you see that applying multiple Guttag-Perchak points in the distal root canal still lead to a proper obturation here. And you also see that the BioRoot is stable after the setting. We see here a sealer surplus, which was intended by me because I assume that there is a periapical or just a resistant biofilm on the root, because we have some resorption in here, and it's a common appearance of an extraradicular biofilm. And I hope for an antimicrobial effect of the BioRoot. So it was intended by me to have a sealer surplus. And we see that the hydrophilic material is still present. So it's not solved and not flushed away. So that's the evidence that the sealer is also setting under a moisture atmosphere. And now let's talk about the criteria and the procedure of obturating large root canals. As I mentioned before, I've also been rooted to the dental traumatology, and as you might know, that's always a trade-off between the treatment capabilities of the patient and the time we need to accomplish the perfect treatment. And when we have an open apex, we are sometimes forced to do an apical plug with a biodentin or some other calcium silicate-based materials. But I would still recommend to use biodentin in these situations because the risk of tooth staining is far more less than compared to another MTA product. So that's the reason why I obturate also these teeth with a biodentin. And there's also another way to obturate these large root canals. We have also the possibility to obturate these large canals in a multiple cone technique, which is not possible with a warm vertical compaction technique or just the conventional quadrilateral compaction. And I will explain how it will work. We see here in this radiograph almost parallel apical designs here. And it's hard to achieve an apical tuckback of the master cone. So when we push hard the master cone, we will go beyond the apex. And you can still say, okay, we can make a conic preparation in there, but we will sacrifice the dentin in this area. So the criteria is for the multiple cone technique to have an almost parallel design of the apex. And you see also this condition in here. A different story is when we have a diverging anatomy in here, we have to go for the apical plug with a biodentin. And how it will work. We place first our master cone with no proper tuckback, and then we place a second master cone to wedge both master cones and to have a good fit there. And that's how it looks clinically. And in this situation, we just melt our gutta percha in here and serve for a good tight seal. And we don't push some pressure on there, so we have not the risk of pushing these gutta percha points beyond the apex. And so we are still saving time in this technique because it's just placing our gutta percha points, cutting them, and that's fine. And I decided in this situation, because of the diverging apex, to place a biodentin in here. And it's more time consuming, to be honest. And when we have to obturate 3 or 4 teeth in the dental trauma, it's still a challenge because the children are not this compliant as we might need for every tooth obturated with a biodentin plug. So we have to emphasize that the BioRoot obturation is not a compromise instead of using biodentin, because the BioRoot offers the same biological seal like the biodentin, but with less effort. And that's also minimalism, the principles of minimalism applied to the obturation of open apices. And now I want to summarize the reasons why I love the BioRoot and why I changed my obturation procedure. There are functional reasons. The first functional reason is the preservation of the dentin. So when we want to reduce our preparation size because it's reasonable, we need an obturation procedure which is not affected by the reduction of the preparation size. So we can reduce our preparation size and preserve dentin in using the single cone technique. And it's also safe for large canals. So we don't need to obturate every large canal with a bioceramic cement like biodentin. And we are saving time and having at least the same good result. And the patient is not asked to sit there for half an hour or so. And the whole procedure is easy and very time efficient. So instead of obturating the canals in half an hour, you can do this in 5, and you can spend more time in disinfecting the root canals. And that's the reason why I would guess that the whole procedure is superior to the warm vertical compaction technique, because we can invest the time for more rinsing the root canals. And then the most important feature for me are the biological reasons. we have a very good interaction with the bone, with the periodontal ligament, as we have seen in the clinical cases, and the interaction with the pulp. And I want to emphasize that these findings are not in vitro studies or clinical studies. These are my own experiences. I see it on an everyday basis, the good effects of the active biosilicate and technology in both in the BioRoot RCS and in the biodentin. And to summarize it, I want to show you again the healing capabilities of both techniques here. We see here the promoted healing by the BioRoot RCS compared to the tolerated material, the epoxy resin-based sealer. And I love that I had performed this split mouth design, and I was surprised by the result that it worked so good. And now we just come back to our principle of the minimalism. We see here that the root canal treatment is still a good procedure, but we have to keep in mind that we can also preserve the pulp vitality. And I want to come back to this because I want to give you the whole picture of my considerations of the endodontic treatment. And instead of the warm vertical compaction technique, we can still use the single cone to be more efficient, to reduce the stress in the root canal system, and to preserve more dentin. And so thank you so much for your attention, and I would really like to have a fruitful discussion.
Hello, welcome back everyone. So thank you so much for following our webinar today, and I hope the lecture was really interesting to you guys. I see that we have quite a lot of people connected today, and we've received a couple of questions, so let's just jump into it and ask you, Dr. Herbst, some questions. So people were reacting to what you were saying during the lecture, and we have one question. Then maybe it's I'll translate it because it was in Spanish. But don't you dry the canals before you do the obturation?
I use paper points for drying the root canals. I try to reduce the fluid in the root canal, but I don't yield to achieve a bone dry environment because the hydraulic material needs water for setting. And the most water is supplied by the dentin, and more precise from the tubules. So when we reduce the amount of water, we will maybe risk the setting of the material. So don't use alcohol for drying out the dentin. So we have to reduce the amount of water, that's clear, but we have to care about the dentin not to have it bone dry. So the recommendation to have a bone dry environment is tailored to the use of epoxy resin-based sealers. So they hate water, and they are hydrophobic. So that's the reason why most of the endodontists or the dentist use alcohol or the excess use of paper points to dry the root canal. But it's a different story for the hydraulic materials. So we have to rethink our protocol when it comes to bioceramic materials. So water is our, but not too much.
Just there's a thin line between no water and too much water. So just have to decide. And maybe there's another question that that can come quite interesting with this subject about drying the canals and preparing the canals for obturation. And maybe if you could tell us a little bit more about your irrigation protocol when you're using a bioceramic sealer, because upon using a bioceramic sealer, it might not be the same as what you did in the past with other types of sealers. So what's your recommendation?
Yes, my recommendation is don't use EDTA or some shellers for the last irrigation, because the calcium silicate based sealer bond to the calcium phosphate. And when you use EDTA, you reduce the amount of calcium phosphate in the superficial layer. And you can use sodium hypochlorite as a final irrigant. So it solves the organic matrix like the collagen, but the calcium phosphate remains unaffected. So that's the main effect we want to achieve, to have as much calcium phosphate and at the surface as possible, to have a proper bond to the material. And Yeah, I just use stereosaline as a final irrigant. So I just flush out everything. So I hope not to have a negative impact on the material. So that's what my protocol was also before I used the BioRoot. So I had not to change anything.
Yeah, so that's what you did before. So great.
Yes.
Okay, so your recommendation, if I understand correctly, is do not use EDTA for the final rinsing, but rather sodium hypochlorite, which is more interesting for the dentin right before obturating with bioceramic sealers.
Yes, and also the rationale about using EDTA is to open the tubules and then to use a disinfectant afterwards to clean the tubules from inside. So there's no reason for me to use EDTA as a final irrigant. So it's also from the endodontic perspective, there's no reason for having EDTA as a final irrigant.
Thank you for this precision. So I have actually, I'm having questions as we speak, so it's quite interesting. It's like a very live discussion. What percentage sodium hypochlorite do you recommend? That's your advice. But,
yes, it depends on the level of training. I know some guys from the US use about 5.25% sodium hypochlorite. For the undergraduate training, we use 1% and not to harm the tissue when they push the sodium hypochlorite beyond the apex. And I use about 3 to 5%. It depends on what's on the market. So I'm not really concerned about the percentage. I recommend to use the fresh sodium hypochlorite out of the bottle and not to store it in the dental office, because you have a degradation and process on the sodium hypochlorite. So when you're unlucky, you just irrigate the root canal with water. So just make sure that you're using fresh sodium hypochlorite during the whole procedure.
Great. That's little tips and tricks like this, which we like. There's a question I read, and if I read correctly, if I understand correctly the question, someone was asking whether you could actually use the warm gutta-percha with BioRoot, which is not something to do. So don't do warm vertical compaction. And I'm speaking as of course, a septodont, but Dr. Herbst, if you want to answer this as well.
Yes, we talked about the amount of water we need for setting, and when you place heat into the root canal, you have an evaporation process. So the water will evaporate, and you have no water to set the material. The material needs the water from the dentin as well as from the material itself. So you mix the material with some fluid, and the amount of fluid is necessary to have a set material afterwards. So when you put your heat plugger in the gutta-percha, we will reduce the amount of water and you will alter the whole material. So when you're completely unlucky, you will have an unset material in the root canal. So I don't recommend to use heat in the root canal when you use hydraulic sealers. You have to
sorry, go ahead.
You have to keep in mind that's a different material class, and every material class and every technique needs some adaptation. So that's very important to distinguish all the techniques available on the market and to tailor your whole procedure towards your favorite material, which I hope it's BioRoot.
If I may say something about BioRoot RCS, because that's from the manufacturer's standpoint. Actually, it was manufactured and was created and was formulated to simplify the whole obturation technique and not use one vertical compaction, but the single cone technique is really recommended with BioRoot RCS. It's simpler, it's faster, it's easier, and that's really the whole point of developing that formulation.
So when you combine everything, you have the most worst things of both worlds. You have the higher preparation size, and you have the higher amount of time you need to accomplish the treatment, and you have an unset material. So it's from different perspectives not recommended.
Yeah. There are more questions coming up. And actually, it's a really interesting one, is about the resorption of BioRoot RCS, that it's highly recommended. And what happens basically when there's an apex protrusion with all sealers, but then with BioRoot RCS especially?
Yes. The process of pushing the material beyond the apex is true for all the materials, that you have a slight discomfort for the patient. So you have a very tight environment at the apex, so there's in a normal situation no space, and so you will have a strong feeling provoked in the patient. And when we have a look on the material, like BioRoot, when you push it beyond the apex, you will have you will have some setting reactions in there, and you will have the release of calcium hydroxide and some ions coming with the material, like calcium, silicon, and hydroxyl ions, which are interacting positively with the cells as well. So you will have maybe a positive effect when you compare it to an initial cytotoxic material like the epoxy resin-based sealer or the zinc eugenol sealer. You will have the potential to have an allergic reaction when you use these material. But we have the opportunity to use a highly biocompatible material, which is not known to provoke an allergic reaction. So I would say when we push the BioRoot beyond the apex, we will have more a positive reaction than a negative one. And as you remember, I've shown a case where I pushed the biodentin, which is quite similar to the BioRoot, in the space between two fragments, and I wanted to have a bony healing, and that's what occurred. So I'm not concerned when the BioRoot is pushed beyond the apex, but for sure we have some discomfort until 1 or 2, 3 days after the treatment, but it's fine.
Okay, so discomfort happens with all types of material being protruded
yes,
on the apex.
That's true for material.
Yeah, every material, but then it actually, since actually BioRoot RCS promotes healing, it's more interesting. I mean, it's better to have that beyond the apex than another material. If I come back, because there's another question, if I come back to the warm vertical compaction versus cold techniques, there's something that's quite helpful. Maybe with the cold techniques also is the shaping. You were discussing minimalistic approach and the fact that you don't do too much shaping, but why is that cold technique allow less shaping than warm vertical compaction?
Yeah, the warm vertical compaction technique needs more space because you have to place your heat plugger, you have to place your cold plugger as well, and you have to melt down the gutta percha up to 2 to 3 millimeters to the apex, and you need space for this. And when you prepare small and you use a warm vertical compaction technique, you will rather have a single cone at the apex than a real warm vertical compaction technique. So you have to prepare larger, for my opinion, when you have the warm vertical compaction technique. And you need also more space when you use the cold lateral compaction technique, because you have also to place your plugger into the gutta percha. And when you prepare very small, you will almost have a single cone at the apex when you use a cold lateral compaction. And when you just have the single cone at the apex, you can have the single cone in the whole root canal. So there is no difference between those techniques. But you have to keep in mind when we talk about the BioRoot RCS that it's about placing the material in the root canal. So the best thing in the root will be the BioRoot, not the gutta percha. So there's a different rationale in obturating the root canal. So it's a bit a modified single cone technique because we want to carry the material into the root canal and to have the effect. And the carrier is the gutta percha, and the gutta percha is not the main reason here for the obturation. So it's just a tool to place the BioRoot in the root canal. So that's what I want to emphasize here.
Great. When we discuss BioRoot and biodentin for that matter, but really BioRoot and bioceramic, there are a lot of different bioceramic sealers available on the market. And are all sealers similar in terms of way you can use them, or in terms of efficiency? I mean, you choose to work with BioRoot RCS. Why?
When we talk about efficiency, we have to distinguish between the technical efficiency, and I would say when you use a single cone technique, it's the same technique for other sealers on the market as well. But when we talk about the efficiency with regards to the healing or the clinical outcome, I would say we will have a different result, because the good thing about BioRoot, and the reason why I've chosen the BioRoot for the sealing material, is because we have the highest percentage of the calcium silicate on the market. And when you take a closer look onto the materials on the market, you will see that many materials are claimed to be bioceramic, but they have very few proportions of calcium silicate in the material. And the calcium silicate is the active component, and the more, the better. So the more calcium silicate you have, the more positive reactions you will have, chemical reactions, and afterwards positive body reactions you will have after you've placed the material. And I would like to expand also on the material class of the epoxy resin, epoxy supported or mixed sealers. When the colleagues say, okay, I will use a light curing bioceramic material, so I would not recommend the light curing materials as well for the same reason, because you have toxic components placed in there, but they are labeled as a bioceramic material. So you have to be, you have to take a closer look on the ingredients in the material and to ask for the percentages from the manufacturer to be on the safe side that it's really a bioceramic material.
Yeah, so you're recommending is basically to be a bit critical about what you're using and checking maybe the composition, because not all are similar.
That's our responsibility as a physician. We recommend to you, we are placing some kind of medicament. We are prescribing something, and we have to be sure what we are prescribing. And that's a duty we have as a physician as well.
Great. I think that we have no questions anymore. If anyone has further questions, we'll be happy to receive them. I think that you have Dr. Herbst email address and web address as well. We can receive questions as well, so if you want to ask more after this webinar, don't hesitate. They will all be passed to Dr. Herbst, and he'll decide. He'll decide. Oh, there's another one. Yep, coming. That's right, Mr. Youssef. That's right. I did not ask this question, but it was a really interesting one. Can BioRoot RCS be used as a plug in case of a curved canal? Last question.
Yeah, for sure you can use BioRoot RCS on the curved root canal, and I highly recommend it to use it, as you've seen in my cases. But as I described earlier, the rationale of the BioRoot is to place it properly in the root canal system, and the material is not intended to use as a plug. When you want to have a plug, you have to use the biodentin to place it and to make a proper sealing. But the BioRoot is not intended as a plug material, because I can't imagine to place the BioRoot properly at the end of the root canal without a gutta percha carrier. And when you're placing the gutta percha in the root canal, you carry it downwards down to the apex, you can still leave it as a master point and as a carrier. And please make sure that you have the correct working length. It's important also when you place the final gutta percha core. So it's not irrelevant to have just some gutta percha in the root canal, but to have the gutta percha at the correct size and the correct length of the root canal. So I would not recommend the BioRoot just to place it like in the syringe at the apex and to see how it's setting, because you're not, you can't control the material perfectly, and you cannot be sure to have some voids in the material. So just place your gutta percha point as you've done it earlier.
Okay, and your recommendation then is to go for biodentin if you need to have a plug.
Yes.
And maybe the fact that I said it was the last question actually prompted more questions, and okay, it's the last one this time. But it's a really interesting one. It's the retreatment. What about retreatment after a BioRoot obturation? Does that occur?
Yes.
For you, Dr. Herbst?
Fortunately, I was not forced to retreat my own cases. And I have no idea about the material which is in the root canal. Maybe I have retreated a BioRoot case from another referring dentist, but I'm not quite sure. But I talked to other colleagues who have experiences with removing the BioRoot RCS, and I said it's not a problem. Because when you have your own treatment placed or your root canal filling placed immediately, and you check it immediately, you can just pull it out and flush out the BioRoot and place it again. And for the set material, you find different results in the studies. Some studies say, okay, it's not a problem to remove it, and some studies say, okay, it's hard to remove it. But anyway, you have your gutta-percha core, and you retreat at first the gutta-percha. And then you will also shape through the BioRoot, and you will give the root canal a new shape. So the material will be removable. And I have some experiences with failed pulpotomy cases because I love to do some experiments with my patient as well. And so I'm experienced in removing the biodentin, and I can say it's really easy to remove. You can just place some ultrasonics in there, and the material will go out. Not easily, but it will go out because you have some adhesion to the dentin.
Great. I think that there are two important things, important key messages to this. You do not retreat your own cases because there's no need to retreat them. So great. And BioRoot RCS can be retreated, yes. That's the end of our webinar today. Thank you so much for attending. Thank you for the wonderful audience. And we're actually very happy that you asked so many questions. Thank you so much, Dr. Herbst, for this wonderful lecture, for being here to answer the questions.
Thank you so much for having me.
Yeah, we've had a great collaboration on this, and we've had a lot of fun. So we hope to do it again very soon. Thank you everyone for attending. Upon closing the webinar, there will be a short survey for everyone, just asking how you thought this webinar was, and just give us your opinion on it. It's always very valuable, and it's feedback for Dr. Herbst, so he always really likes it and craves it. And stay tuned for the next webinar. Thank you very much. Have a great evening. Have a great day.